Evening, and welcome to tonight's Institutional Perspectives in Cancer, focusing on the use of immunotherapies. My name is Donna Short. I'm the Executive Vice President for Global Ambassador Strategies at MJH Life Sciences. MJH Life Sciences is the parent organization for OncLive, and this is an OncLive program. Tonight, OncLive receives support from Bristol Myers Squibb and Regeneron, and we'd like to thank them for their support. So I'm going to cover a couple of housekeeping notes before I turn the program over to Dr. Hamid. At the top of your screen, you'll see a tab that says Meet My MSL. This is an opportunity for you to sign up to receive an email from OncLive regarding the Meet My MSL app. OncLive is developing this app to connect physicians with MSLs across the industry and make sure that you can find people based on molecule or disease state. So look for this app to come live soon. We also have at the top of your screen a tab that says Giants of Cancer Care. We've opened the nomination process for the 2023 class for Giants of Cancer Care. The nomination process will close at the end of January. So we want to encourage you all to nominate someone who has mentored you or gone before you and truly helped you in your career. This comes from the phrase standing on the shoulders of giants, and you can all recall someone who's paved the way for your own success. So take an opportunity to honor them. Giants of Cancer Care is the only peer-nominated, peer-voted, and peer-awarded award in oncology. And again, take an opportunity to honor someone. There's also a Q&A box at the bottom of your screen. I forgot to warn Dr. Hamid that I was going to do this. Go ahead and tap on the box, type in your first and last name and your institution, and hit submit. This is a great way to let Dr. Hamid know that you're in the audience, and it'll clog up his Q&A box. We'd also like to ask you to use the Q&A box throughout the program to ask any questions as they occur to you. All questions will be handled at the conclusion of the program during the panel discussion, so we'd like you to stay till the end too to hear the answers to your question. On the bottom of the screen, you'll see some really awesome capabilities. One button says Save a Slide, the other says Take a Note on a Slide. If you take a note on a slide or hit Save a Slide, these slides will then be sent to you post-program as a PDF, so take advantage of that capability. And finally, there'll be a drawing for 2 $150 Visa gift cards at the conclusion of the program for all healthcare providers who pre-registered and stay till the end. So be sure to stay till the end so you can hear your name being called out. Also, after the program, there'll be a survey sent to you. We'd like to ask you to fill out the survey with as much content and clarity as you can provide around your feedback. All folks who are pre-registered and healthcare providers who do the survey will be registered in a drawing for an Apple AirPod Pro 3 set of earbuds. So take advantage of that and get your survey back to us. Part of the joy of my job is that I get a chance to work with our chairs. And our chair this evening is Dr. Omid Hamid. He's the Chief of Translational Research and Immuno-Oncology Department in the Angeles Clinic and Research Institute, a Cedars-Sinai affiliate there in Los Angeles. Dr. Hamid.
Well, thank you for that lovely introduction. I appreciate the ability for us to come together and talk about immunotherapy and where it's gone in solid tumors. It's been a great journey for us here at Angeles as we've been part of the phase 1 trials of the majority of these drugs and have helped to bring these to the clinic. Today, we have a great group of people who have amazing background. Dr. Anibal Manoukian to talk about lung cancer, and Durjit Mimi to talk about cutaneous malignancies, V2 about GI malignancies, and Dr. Wenzel to talk about GU malignancies. I've been tasked with saying one great thing that you didn't know about him, a fun fact. It's important to know that Dr. Manoukian is a big Outlander fan. and she brings that same enthusiasm to care for her patients. Dr. Memi goes nonstop as a competitive biker, not the Yamaha and Kawasaki type, but the one you pedal yourself. So he's got a lot of energy. Dr. Wenzel is a grand chef. He puts lots of great food together, great recipes, similar to how you put a program together for your patients. And there's no one who's traveled and trained like Dr. Chu, who has begun his training at Memorial Sloan Kettering. As a fellow, he was a resident in Texas at UT Southwestern. He did a postdoctoral fellowship at the Institut Pasteur in France. He was assistant professor at Irvine and then moved to New Mexico and finally found a home here at the Angeles Clinic and Research Institute. So we've had a great opportunity here, and we look forward to educating you as colleagues on what's new and upcoming in all cancers. We'll begin with Dr. Balmanukian, who's been here for the longest time and is also co-director of the phase 1 program here, as she will update us in non-small cell lung cancer. Dr. Balmanukian.
Thank you so much, Dr. Hamid, and thank you everyone for joining us. It's a pleasure for me to be here and specifically discuss the use of immunotherapy and updates in using immunotherapy in non-small cell lung cancer. We have a number, this is just a quick disclosure for me. We do have a number of trials to go through, and this just highlights the progress we have made in the treatment of non-small cell lung cancer. We'll be talking about updated trial results for Checkmate 227 and Checkmate 9LA, which are providing new treatment options like non-small cell lung cancer using IO therapy. We'll also discuss the data in the Empower Lung 3 trial. And then more recently, of course, which is very exciting data, we now have approval in using IO in combination with chemotherapy in the neoadjuvant setting. And that specifically is data pertaining to Checkmate 816 trial, which we will be discussing as well. So to start off, we'll discuss the therapy for recurrent metastatic non-small cell lung cancer. And Checkmate 227 is a trial we are all familiar with. And the most recent data was updated at ASCO, and that's the data we'll be discussing today. And this is the 5-year survival outcomes with using nivolumab plus ipilimumab versus chemotherapy as frontline treatment for patients with metastatic non-small cell lung cancer. Now, Checkmate 227, as everyone is likely familiar with, this was for patients with stage 4 or recurrent non-small cell lung cancer. Patients should have been treatment naive. They could not have had an EGFR mutation or ALK alteration, good performance status, and they could not have had an untreated brain metastasis. Stratification was performed via squamous versus non-squamous histology. Now, this trial was a 2-part trial. So in part 1A, patients had to have a PD-L1 expression of greater than or equal to 1%. Part 1B was for patients with greater PD-L1 less than 1%. So part 1A greater than or equal to 1%, part 1B less than 1%. In part 1A, stratification was 1 per 1 by 1 for patients to receive nivo plus ipi versus chemo versus nivolumab as single agent. And same with part 1B, where patients were stratified to receive nivo plus ipi versus chemo versus nivo plus chemo. And the independent primary endpoints were progression-free survival in patients with high TMB, which was labeled as greater than 10, and overall survival, and specifically for the group with PD-L1 greater than or equal to 1%. And in the 5-year overall survival data, we now see that the group who received ipi plus nivo had a significant overall survival benefit in comparison to the group who received chemotherapy as well as to the nivo monotherapy. So in the 5-year overall survival data, we have overall survival of 24% for the group who received ipi nivo versus 14% in the group who received chemotherapy, and then 17% for the nivo group. In terms of progression-free survival, we also see 5-year progression-free survival benefit in the group who received ipi-nivo at 12% versus 2% with chemo and 9% with nivo. So at the 5-year mark, we have both overall survival and progression-free survival benefit. That was for patients who received ipi-nivo. And one of the more impressive data for this study, to me at least, was the duration of response. We know that when we have patients who are treated with immunotherapy, we do get these amazing durability of responses that then lends to the fact of how immunotherapy may work. And in terms of the duration of response, we do see substantial benefit in median duration of response, which with the group who received ipi-nivo was 24.5 months versus 6.7 months in the group who received chemotherapy, which is on par with what we see in those patients who usually get treated with chemotherapy, is that on average, their duration of response is about 6 months. But with the group who received ipi-nivo was 24.5 months. And certainly we do see that updated 5-year data as well here in the group benefiting the group who received ipi-nivo. Now, the question regarding the patients who had PD-L1 less than 1%, we do see that there was overall survival benefit in that group as well at the 5-year mark, so 19% with ipi-nivo versus 7% with chemo, 10% in the group who received nivo plus chemo. Progression-free survival, again, we see the benefit in the group who received nivo plus ipi versus chemotherapy, 10% versus 2%. Again, this is for the group who had PD-L1 less than 1%. And same as well for the duration of response, where we do see median duration of response of 19.4 months in the group who received nivo plus ipi versus only 4.8 months in the group who had received chemotherapy. So now we do have 5-year overall survival data for CheckMate 227. And as we know, ipi-nivo is approved for patients in the frontline setting, and for those specifically for PD-L1 greater than or equal to 1%. Now, moving on to CheckMate 9LA, this also used ipi plus nivo in the newly diagnosed metastatic setting, but using as well with 2 cycles of chemotherapy. So this was frontline nivo plus ipi plus 2 cycles of chemotherapy versus chemotherapy in patients with metastatic non-small cell lung cancer. Now, we're all familiar with the CheckMate 9LA data as well. However, this data was updated to provide 3-year overall survival data at just this past ASCO last month. Now, in terms of the design, this also to enroll patients with stage 4 or recurrent non-small cell lung cancer who are treatment naive, again, excluding patients with EGFR mutation or ALK alteration, good performance status, stratification performed by PD-L1 less than 1% or greater than or equal to 1%, sex and histology, squamous versus non-squamous histology. Now, in this study, which was very interestingly designed, patients were stratified 1-to-1. In the IO group, patients received ipi plus nivo. Here, nivo was flat dose at 360 mg every 3 weeks, and ipi was 1 mg per kg every 6 weeks. And then with chemotherapy, but chemo was only for 2 cycles. So 2 cycles of chemo plus immunotherapy, and then you drop the chemotherapy and just continue with ipi-nivo afterwards. The comparator arm only received chemotherapy, and patients received treatment until disease progression, unacceptable toxicity, or for up to 2 years. And primary endpoint here was overall survival. And then there were some secondary endpoints, including progression-free survival, overall response rate, as well as efficacy by tumor PD-L1 expression. And here at the 3-year mark, we do see overall survival benefit for the group who received ipi-nivo plus chemo versus limited chemo versus chemotherapy. So 27% overall survival versus 19% in the chemotherapy group. Median overall survival of 15.8 months in the ipi-nivo plus limited chemo versus 11 months for chemotherapy. And the reason why we give only 2 cycles of chemotherapy and then drop chemo and continue with immunotherapy here is that this is intended for those patients who really need that immediate cytoreductive effect from chemotherapy. And then you're essentially dropping the chemotherapy and allowing patients to only move forward with immunotherapy, given we know the durability of responses with immunotherapy, they're better tolerated. So really you're just using chemotherapy, just limited in the upfront setting for that immediate cytoreductive effect. And in terms of overall survival, based on PD-L1 expression, we do see overall survival benefit regardless of PD-L1 expression. So less than 1% versus greater than 1% here on the right. We see overall survival data at the 3-year mark, regardless of PD-L1 expression, benefiting patients who received ipi-nivo plus limited chemo versus chemotherapy. So here on the left, 25% versus 15% in the PD-L1 less than 1%. Here on the right, we see overall survival 28% in the ipi-nivo plus limited chemo versus 19% overall survival in the chemo group for those PD-L1 greater than 1%. And in terms of further division of PD-L1 status, on the left here, 1 to 49% versus on the right, PD-L1 greater than 50%. We see that regardless of the PD-L1 expression, again, regardless of the group, we are seeing a benefit for those patients who received ipi-nivo plus limited chemo versus chemotherapy. Same with progression-free survival, where we see for all randomized versus division between PD-L1 less than 1% or greater than 1%, we're seeing progression-free survival benefit for the group who received ipi-nivo plus limited chemo versus chemotherapy. So again, here in this update for Checkmate 9LA, we're seeing a 3-year overall survival benefit, progression-free survival benefit for the group who received ipi-nivo plus limited chemo versus chemotherapy. Moving on to Empower Lung 3. So this is a trial using cemiplimab, which we know is an anti-PD-1 antibody, in combination with platinum doublet chemotherapy for frontline treatment of advanced non-small cell lung cancer. This data was presented at ESMO last year. And this is a trial where patients, again, who were treatment naive with advanced non-small cell lung cancer, which included both non-squamous and squamous histology, were enrolled. Now, patients were allowed to enroll if they had stage 3B, C disease, or stage 4, regardless of PD-L1 expression. Again, no EGFR or ALK or ROS1 mutations were allowed, good performance status, and treated clinically stable CNS metastasis were allowed. Stratification factors included PD-L1 expression, so less than 1% versus 1 to 49% versus those greater than 50% PD-L1 expression, as well as histology, so non-squamous versus squamous. The primary endpoints here were overall survival, and then the key secondary endpoints were progression-free survival, overall response rate, and then additional secondary endpoints, duration of response, best overall response, as well as patient-reported outcomes. Stratification was done 2-to-1. So the group who received cemiplimab received 350 milligrams IV every 3 weeks, and investigator's choice of platinum doublet chemotherapy for 4 cycles. The comparator arm received placebo every 3 weeks, plus investigator's choice of platinum doublet chemotherapy. And treatment was continued until disease progression or for 108 weeks in either arm. And here what we see is overall survival benefiting the group who received cemiplimab plus chemo, a 12-month overall survival of 65.7% in the group who received cemiplimab plus chemo versus 56.1% in the group who received chemotherapy plus placebo. In terms of median overall survival, that was 21.9 months for the cemiplimab plus chemo arm versus 13 months for the placebo plus chemotherapy arm, for a hazard ratio of 0.71. We also see progression-free survival benefit in the group who received cemiplimab plus chemotherapy, where the 12-month progression-free survival was 36.1% versus 16.4% with chemotherapy, for a median progression-free survival of 8.2 months with cemiplimab plus chemo versus 5 months for placebo plus chemotherapy. In terms of tumor response, the overall response rate of cemiplimab plus chemotherapy was 43.3% versus 22.7% for chemotherapy only. We do see complete responses in the cemiplimab plus chemotherapy arm, where complete response was 2.6% in the cemiplimab plus chemo group versus none in the chemotherapy group. The partial response here in the cemiplimab plus chemo was 40.7% and versus partial response of 22.7% in the chemotherapy arm. And so we do see substantial benefit of the addition of cemiplimab to chemotherapy for patients in this newly diagnosed setting for non-small cell lung cancer. Also looking and seeing that there is a benefit to median duration of response, again, lending to the fact that we do see these durability of responses with the use of immunotherapy. The median duration of response in using combination cemiplimab plus chemo was 15.6 months versus 7.3 months in the placebo plus chemotherapy group. When we look at the subgroup analysis here on this forest plot, we do see that in terms of overall survival on the left and progression-free survival on the right, majority of the subgroup analyses benefited the group who received cemiplimab plus chemotherapy, with very minor outliers, but majority did benefit regardless of race, histology, PD-L1 status, those who were in the cemiplimab and chemotherapy arm. Now shifting gears to neoadjuvant therapy. So we saw that there's new data and updated information in terms of metastatic non-small cell lung cancer. The treatments we discussed, so ipilimumab and nivolumab are approved in the newly diagnosed setting. Checkmate 9LA regimen with ipilimumab plus chemotherapy, limited chemotherapy is also approved. And Power Lung 3 is now sitting with the FDA. And so all of these are adding choices to patients in the metastatic setting. And now, because of all the progress we have made, now we're actually able to discuss data in the neoadjuvant setting. Again, moving the needle forward and providing opportunities for patients to receive immunotherapy in the more upfront setting and providing them, exposure to immunotherapy earlier on. Now, Checkmate 816 was neoadjuvant using neoadjuvant nivolumab plus platinum doublet chemotherapy versus chemotherapy for resectable stage 1B to 3A non-small cell lung cancer patients. And the updated here in terms of updated information from ASCO of this past year was association of pathologic regression with event-free survival in this data, which we'll talk about shortly. In terms of the design for Checkmate 816, this enrolled patients with newly diagnosed resectable stage 1B and those patients who had greater than 4 centimeters of disease, 2, 3A non-small cell lung cancer patients. And the staging system here was the 7th staging. We now have the 8th staging, but when this trial was set forth, it was using the 7th staging. Patients had to have a good performance status. Again, no EGFR mutation or ALK alteration, and stratification was performed via staging 1B to 2 stage versus 3A, PD-L1 status greater than or equal to 1% versus less than 1%, as well as sex. Patients were randomized 1-to-1 to receive nivolumab at a flat dose of 360 milligrams IV every 3 weeks, along with chemotherapy every 3 weeks for 3 cycles in the neoadjuvant setting, versus chemotherapy only for 3 cycles, again in the neoadjuvant setting. Patients had to have a radiologic restaging and then subsequently undergo surgery within 6 weeks of post-treatment. And then subsequently, patients can receive optional adjuvant chemotherapy or radiation and then follow up afterwards. Primary endpoints here were pathologic complete response rate, as well as event-free survival. And then secondary endpoints were major pathologic response, overall survival, and time to death or distant metastasis. Now, in terms of pathologic complete response rate, we do see an impressive 24% pathologic complete response rate in those in the group who received chemotherapy plus nivolumab in the neoadjuvant setting versus only 2.2% rate of pathologic complete response in the group who received chemotherapy. In terms of median event-free survival, to clarify, was defined as time from randomization to disease progression, and pathologic complete response rate was 0% residual visible tumor cells in the primary mass and sampled lymph nodes. So in terms of event-free survival, that was 31.6 months in the group who received nivolumab plus chemotherapy versus 20.8 months in the group who received chemotherapy alone. And in terms of median overall survival, that was not reached at the time of this analysis, and that data is maturing at this time. Now, in terms of the updated information that was provided at ASCO and presented at ASCO this year, looking at the event-free survival by pathologic complete response rate status, we do see that for the group who received nivolumab plus chemotherapy, for those who achieved the pathologic complete response rate, as we see here on the left, those had a better and higher percentage of event-free survival reach a pathologic complete response rate. Same is true of the chemotherapy group. I would have to point out the fact that those who received pathologic complete response rate in the chemotherapy group were only 5 patients versus 46 patients in the group who received nivolumab plus chemotherapy. And same holds true regardless of staging for those who had a pathologic complete response rate based on stage 1 to 2 disease. Those had a better event-free survival versus those who did not have a pathologic complete response rate. Same with the stage 3A disease patients as well who received nivolumab plus chemotherapy. And same is true of those who had PD-L1 less than 1% or greater than 1%. So what we see is regardless of staging or PD-L1 status, those who had a pathologic complete response rate with the addition of immunotherapy with nivolumab to chemotherapy actually had a better event-free survival rate. So in conclusion, in the trials that we discussed, in the metastatic, recurrent and metastatic setting for non-small cell lung cancer, we have CheckMate 227, which is for patients with, so it has approval for the use of ipilimumab plus nivolumab for patients with non-small cell lung cancer with PD-L1 greater than 1%. We see 5-year overall survival of 24% for the group who received ipilimumab plus nivolumab versus 14% with chemotherapy. In CheckMate 9LA, for patients with metastatic recurrent non-small cell lung cancer in a newly diagnosed setting, regardless of PD-L1 expression, we now have 3-year overall survival data where we have overall survival of 27% for the group who received limited chemotherapy plus ipi plus nivo versus 19% overall survival for the group who received chemotherapy. In Power Lung 3, we see that's the combination with cemiplimab, anti-PD-1 antibody plus chemotherapy in the newly diagnosed setting. We see a median overall survival of 21.9 months with the combination of cemiplimab plus chemo versus 13 months for chemotherapy. And now in the neoadjuvant setting, we have CheckMate 816, which does have approval to be used in the clinic where the combination of chemotherapy plus nivolumab in the neoadjuvant setting noted a pathologic complete response rate of 24% versus only 2.2% in the group who only had chemotherapy, with an event-free survival of 31.6 months in the group who received chemotherapy plus nivolumab versus 20.8 months in the group who received chemotherapy. So as we see here, we've made substantial progress in regards to all the data and all the treatment options that are available for patients. And I can only see the field moving forward and patients overall just doing better with all the treatment options that we have for them. And with that, I thank you.
Thank you for that. Right on time. I appreciate it. And we'll now transition to Dr. Memi and his discussion about cutaneous malignancies. I would like to say that most of immuno-oncology and checkpoint comes from the beginnings in melanoma, whether it's neoadjuvant therapy, metastatic therapy. So it's clear that to pay close attention to these slides. So Dr. Memi, please take us through this ride.
Yeah, thank you very much. And I completely agree. The immuno-oncology field literally started with, treatment paradigm, in melanoma. So, so today we're going to try and look at some of these trials that led to approval and the subsequent expansion into other solid malignancies. So I'm going to try and talk about some of the early stage disease treatment of cutaneous melanoma, node negative and node positive, and then we'll look at some of the unresectable advanced disease treatment by the way of talking about Relativity 047, a newly approved combination, and also DreamSeq, ECOG 6134, trial that actually is essentially changed practice in terms of what we use in the frontline setting for BRAF mutated melanomas. And after that, I'll spend a little bit of time on some of the other rare forms of melanoma and additional treatment options for cutaneous and non-cutaneous melanoma in terms of muteins and adoptive T-cell therapies. And we'll also spend a tiny bit of time on individuals with metastatic disease to the brain from melanoma and how to manage those. So we'll dive into the adjuvant therapy for melanoma. As you know, not all of the melanoma are node positive, and significant number of patients present with node negative disease. But a proportion of those node negative disease being stage 2B and 2C actually have a higher risk of recurrences than some of the node limited, like stage 3A, for example. So to address those high-risk node-negative melanoma patient, Keynote 716 was designed a randomized double-blind phase 3 study to see if there is a benefit of adjuvant pembrolizumab for these patients. And this trial looked at 976 patients and one-to-one randomization with the intention to treat population. And most of these patients, in terms of each group, were very similar, with a median age of 61. Female and male were very much similar in both of the groups. And at the first interim analysis, so essentially these were widely, they had wide local excision, and after that, they, in addition to sentinel lymph node biopsy, and these were all sentinel lymph node negative patients and without any systemic disease as their inclusion-exclusion criteria. And at the first interim analysis, showed that individuals or the subjects who were treated with pembrolizumab, they had about 11% recurrence, whereas the placebo group had 17% recurrence, showing a benefit even at the first interim analysis, which was very encouraging, with a hazard ratio 0.65. Subsequently, about a year later, a second interim analysis occurred that showed that there in the pembrolizumab treated group, the first recurrence was only in about 15% of the patients, whereas placebo had 24. Again, the hazard ratio for relapse-free was 0.61. And for any median recurrence-free survival was not reached, and that's probably because the follow-up period is small. And very recently, Dr. Long from Australia updated us on this trial about this survival-free benefit, which was maintained as seen on the first and the second interim analysis with a hazard ratio of 0.64. This is illustrated further in these two graphs. The first graph here on the left is your first interim analysis, and the second one on the right is the second interim analysis, again showing that individual who had stage 2B or 2C melanoma, lymph node, sentinel lymph node negative, did benefit from pembrolizumab. The subgroup analysis also showed that almost all of the patients that were treated with pembrolizumab did benefit. After looking at the node negative population, the subsequent group is node positive, which has the highest risk of recurrence. And so far, we've had 2 different agents approved in this space, with the Checkmate 238 looking at nivolumab based on the relapse-free survival data, and also pembrolizumab based on the Keynote 054 data for relapse-free survival. And we don't have any overall survival data from these 2 trials yet. The third trial, a very important trial in my opinion, Moderna mRNA-4157, a personal cancer vaccine study, also known as Keynote 942, which looked at mRNA-4157 designed from each patient's tumor plus or minus pembrolizumab. It's completed accrual and we're waiting for its results. The third trial that held very much promise but has been suspended by sponsor was the NKTR214, which is a modified IL-2 interleukin-2 plus minus nivolumab in node positive melanoma. So since the suspension of this study, we are excited about the next trial in adjuvant setting, which is looking at node positive, which means stage 3A and beyond, resected melanoma without any systemic disease. Can we move the needle of relapse-free survival further than what nivolumab and pembrolizumab have done? And for this approach, nivolumab plus minus relatlimab, which is a LAG-3 monoclonal antibody in BMSC 224-098 study is being conducted and currently open at the Angeles Clinic. And some of the key inclusion criteria are age greater than 18, completely resected melanoma, stage 3A, where the lymph node burden is greater than 1 millimeter, and stage 3B, C, D, or even stage 4 that's fully resected without any residual disease. And here we're looking at a total of 1,050 patients that'll be randomized 1-to-1, and one group will get relatlimab and nivolumab as a single infusion every 4 weeks versus nivolumab 480 milligram at flat dose every 4 weeks, and they'll be followed up to 6 years. And like I said, this study is currently open, and we're very excited about this in adjuvant setting. So let's move on to, due to the limit in time, we'll talk about some of the basic concepts in advanced melanoma. And I wanted to talk about LAG-3 molecule itself, the newest checkpoint inhibitor that has been approved in advanced melanoma. And a little bit of background on LAG-3 is it stands for which is not present on naive T cells, but it's induced in its expression on CD4 positive T cells. Its expression can also be induced by interleukin-2, interleukin-7, and 12. Its usual function is inhibitory, and continuous stimulation of LAG-3 by either any of the infectious agents or tumor cells leads to an exhaustive phenotype on the T cell, and it's unable to mediate its cytotoxic function onto the tumor or its other targets. Here's a little schematic showing you that. So based on that basic science principles in immunology, a trial of relatlimab with nivolumab versus nivolumab alone in untreated advanced melanoma has taken place, and this was known as the Relativity 047 study. Again, this is a phase 3 study looking at the combination of these two drugs versus nivolumab alone in 714 patients who were treatment naive, had either advanced stage 4 or unresectable melanoma, with the primary endpoint of PFS, progression-free survival, with the secondary endpoint being overall survival and overall response rate. These patients were stratified according to LAG-3 expression, PDL expression, LDH at baseline, and BRAF status. Here are some of the key data from this study. Shows that when you're looking at 355 patients that were treated with relatlimab and nivolumab, their median progression-free survival was 10.12 months versus nivolumab alone, which was 4.63 months with a hazard ratio of 0.75 and a p-value of 0.06. Here's a Kaplan-Meier curve showing the progression-free survival advantage when you're using relatlimab plus nivolumab versus nivolumab alone. And based on this data, FDA has approved this combination to be used in first-line setting, regardless of patient's LDH, BRAF, or LAG-3 or PDL1 status. I apologize for this figure being too small, but as you can see that all of the groups have benefited from this combination versus nivolumab alone. And with respect to the adverse events, this combination is very well tolerated, and adverse events are very similar to what nivolumab had to offer. The frequency wasn't any more higher that would cause a great concern. So the next trial or the study I wanted to highlight was the BRAF mutated metastatic melanoma population. As you know, that there are about close to 50% of the patients of cutaneous melanoma that have this mutation. And there are 3 different combinations that are already FDA approved for this population. And they're readily available in clinic to be used based on their PFS and overall survival benefit. But if you look at Checkmate 067 data that had a significant number of BRAF mutated melanoma participants, their 6.5-year updated data shows that even the BRAF mutated patients benefited from frontline immuno-oncology agents, this being IPI and NIVO here. So that presents us with the question, what should we use first? Should we go with BRAF targeting therapy versus IPI-NIVO for these patients? And this question was answered based in this particular study called DREAM-seq or ES6134. It's an ECOG cooperative study. Looked at 300 patients that were treatment naive, BRAF V600E or K mutated, with a primary endpoint of 2-year landmark overall survival. And the expected benefit was 70% for the immuno-oncology treated and 50% for the targeted therapy. And the secondary endpoints were 3-year landmark overall survival and some other safety and overall response and PFS benefit as well. Here was the schema of this particular study. BRAF mutated patients with a stratification of ECOG, LDH, and they were split into randomized to 2 arms. One arm received ipi/nivo, the other arm received the dabrafenib trametinib continuously. And once they progressed, then they were flipped onto the other treatment. And I will direct your attention to this very nice Kaplan-Meier curve that shows individuals who were treated with immuno-oncology drugs, ipi/nivo, they did much better in terms of 2-year overall survival benefit. As a matter of fact, this trial met its endpoint of the 20% difference they were looking at. The dabrafenib trametinib group, 2-year overall survival was 52% versus ipi/nivo treated group, 2-year survival was 72%. Here's the progression-free survival analysis of this group, again favoring ipi/nivo. Initially, this was a much larger study in its planning, but due to the benefit that it demonstrated, it was halted earlier. And some of the details I wanted to highlight for this is the ipi/nivo dose used in study is the ipi3 and nivo1 that were given every 3 weeks, followed by maintenance nivo. So basically, this has answered our questions that for BRAF mutated patients, we should essentially use ipi/nivo in the first-line setting. The little time that I have, I wanted to spend on tebentafusp, which is a T-cell engager, newly approved agent for for uveal melanoma in individuals who are HLA positive, showing overall survival benefit. And even in patients who had progression of disease, once they were treated with tebentafusp, showed overall survival advantage. And this is, again, readily available in clinic that should be used in the frontline setting for advanced uveal melanoma. Not only in advanced uveal melanoma, tebentafusp has its application in cutaneous melanoma, and currently we are running, participating in the clinical trial for tebentafusp in cutaneous melanoma as a subcutaneous dosing mechanism. So that option is also available here. The next agent I wanted to highlight was modified interleukin-2 as Elkerims's 4320 agent for mucosal melanoma that's shown benefit in up to about 40% of the patients. As you know, that mucosal melanoma is a small group of patients under the umbrella of melanoma in general. But very difficult to treat, and most of the time patients don't do all that well on cutaneous melanoma regimens. So it appears that interleukin-2 is probably a very good agent here, and currently we are participating in a registration study here at Artistry 6 at the Angeles Clinic. The next talk of the town in advanced melanoma is tumor infiltrating lymphocytes. And we've seen a number of studies actually as recently as 2-3 days ago from a European group that has met its endpoint when compared to ipilimumab. In addition to that, our centers participated in this particular trial by Iovance looking at lifileucel in advanced or refractory melanoma that have been treated with prior immuno-oncology and targeted therapy agents, showing a benefit of nearly 40%, again, in refractory setting. And a lot of these patients have received ipi/nivo or BRAF inhibitors or other additional therapies with ongoing benefit. And this is currently in front of the FDA, likely to be approved soon. Lastly, I wanted to highlight the very difficult to treat patient population, metastatic melanoma with the brain metastases. And these are the patients who in the past were relegated to surgeries versus radiation. And we continue to use those options, but without any additional mechanism for control. To study this, there's a large group of clinicians that have come together to look at nivolumab and ipilimumab at standard dosing to see if we can control some of these brain mets. As you can see, that this particular brain met study looked at intracranial, extracranial, and global control at almost in all situations. There are about 50% of the patients that have attained good control over the disease. One of the key points here is that some of these patients had asymptomatic untreated brain mets that continue to respond, and they've lived showing overall survival benefit here at 12 months and onwards. In conclusion, we've talked about the adjuvant setting for node negative and node positive applications, and also the treatment sequence for BRAF mutant, where the answer should be ipi/nivo unless it's contraindicated. And we also touched a little bit on tebentafusp in uveal melanoma and its ongoing studies and ability to apply in cutaneous melanoma. We also touched slightly on ALKS4230, a mutant of interleukin-2 in mucosal melanoma and adoptive T-cell therapy, and also how to manage some of these brain metastases from melanoma. I apologize for rushing some of these last topics due to lack of time, but if there is any particular question, I'll be happy to answer those.
Okay, so that was great. I will say that there were lots of information touched upon there that we could hit in the question and answer session towards the end. I want to stress that we can take questions as you want. Please put them in the question area. Thank you for those who've done that so far. Dr. Memi hit on some themes that are in every solid tumor as bispecifics are coming into other solid tumors. There's great data from 227 in brain mets, which we'll discuss later for lung cancer and immunotherapy. But the greatest, and the most influential data came out in GI cancer. And some of you have seen it. It was presented in New England Journal of Medicine. It made every one of my patients want to go over and be taken care of by Dr. Chu, which was fine by me. But there is great answers to questions for other solid tumors, and those that are previously thought to be the most refractory to immunotherapy in GI cancer. So welcome Dr. V. Chu, who's the Director of GI Oncology here at the Angeles Clinic and Research Institute. Dr. Chu.
Well, thank you for that introduction. So I will discuss today about immunotherapy in GI cancer. As we all know, there's a robust correlation between tumor mutation burden and PD-L1, PD-1 response with a correlation coefficient of 0.73, as shown in this diagram. Unfortunately, the main GI cancer that is highly responsive is MSI high or dMMR colorectal cancer. Most of the other GI tumors have either low, as in pancreatic or colorectal, or low moderate level of TMB as an anal hepatocellular gastroesophageal. So today I'm going to sort of give you a broad review of frontline treatment and the progress that's been made with immunotherapy in the frontline setting, and that'll be clear why I'm focusing on the frontline setting toward the later end of the talk. So we will look at GI cancer starting with MSI-high tumors, followed by HCC, followed by anal squamous cell carcinoma, gastroesophageal, and then biliary tract cancer. And then we will talk about how the benefit of efficacy occurs with early exposure. And I'll show you some of the data that was presented at ASCO, which was really exciting. So in the frontline setting, there are multiple progress that was made with positive phase 3 trial, including the groundbreaking Keynote 177, the IMbrave 150, the Topaz, and the Checkmate 649 trials, and I'll go over those in detail. There were also some negative phase 2-3 trials, Keynote 062 in gastric cancer, the SCARSI POD 60, and the Checkmate 9X8, which were also informative, even though they were negative trial overall. So starting with the Keynote 177 trial, would look at standard of care chemotherapy versus pembrolizumab in first-line MSI-high metastatic colorectal cancer. This involved 307 patients. Of note, in standard of care patient with chemotherapy, K-Fox, FOLFOX, or other chemotherapy, they were allowed to cross over upon progression. The primary endpoint are shown in bold, with median progression-free survival superiority with pembrolizumab was 16.5 versus 8.2 months. The median overall survival was not reached in the pembrolizumab arm and was 36.7 in the standard of care chemotherapy arm. That was not statistically significant, but again, I think that's due to the crossover that was permitted. Overall response rate was higher with immunotherapy. I think when you look at this data, one thing to note is that early on, chemotherapy, because it tends to give a faster response, does a little better than immunotherapy, but the more important emphasis is on the durability of pembrolizumab response. So you get a plateau in the tail of the data, and that, to me, out 5 years indicates either the patient is in remission or they're basically cured. So that's the main emphasis with immunotherapy, is that some of these patients in metastatic setting are getting cured. Next, we will focus on the IMbrave 150 trial, which involved Child-Pugh A hepatocellular carcinoma of 501 patients in the first-line setting of those patients who were unresectable. So sorafenib has been the standard of care for a very long time, over a decade. And there are other TKI like lenvatinib and regorafenib were also approved. But the IMbrave 150 trial was able to show that atezolizumab plus bevacizumab gave superior primary endpoint of median progression-free survival of 6.8 versus 4.3 with sorafenib, and also median overall survival that was not reached, but was superior versus 13.2 months with sorafenib. Again, the overall response rate was higher. Next, we have the Topaz 1 trial, looking at a mixture of advanced biliary tract cancer. There was 685 intrahepatic and extrahepatic cholangiocarcinoma and gallbladder patients. It was comparison of gemcitabine cisplatin in the frontline setting versus gemcitabine cisplatin plus durvalumab immunotherapy chemotherapy combination. Again, we see that the median overall survival was superior at 12.8 versus 11.5. And the median progression-free survival was also improved of 7.5 months versus 5.7 months. Again, we see that when you combine chemotherapy with immunotherapy, the overall response rate is also higher. Now, one thing to take note is whether this is a additive effect from chemotherapy added to immunotherapy, or is there the ability to get a synergistic effect? I think those are an unanswered question. I mean, ideally, we would want a synergistic effect where immunotherapy does more than just add on to chemotherapy. More recently, we have this Checkmate 649 trial, looking at advanced gastric or esophageal adenocarcinoma. So this trial was a bigger trial, but I'm going to focus on the patient that has a combined positive score of greater than 5 for the PD-L1 expression, involving 955 patients. Here we compare first-line chemotherapy compared to chemotherapy plus nivolumab. Now, the chemotherapy in this setting is FOLFOX or CAPOX, and it was seen in the frontline saying that the primary endpoint of median progression-free survival was superior with the chemotherapy immunotherapy arm, 7.7 months versus 6.0 months, and median overall survival of 14.4 versus 11.1 months. And 14.4 months for metastatic gastroesophageal adenocarcinoma is very impressive, considering that previously it was under a year. Again, you see that the overall response rate is higher at 60% versus 45%. And because you're adding on the chemotherapy to the immunotherapy, you don't see early on the superior of chemotherapy because obviously the patient are getting it. So now there's now I'm going to focus on some of the negative trial, and the reason for that is to highlight that when we're adding on chemotherapy to immunotherapy, there may be potential for not just a additive effect, but also I think in this case in the KEYNOTE-062 trial, there might be a immunosuppressive effect of chemotherapy. Now this is just a hypothesis, but I thought it was interesting. Here in the KEYNOTE-062 trial, the chemotherapy component was cisplatin 5-FU, not CAPOX or FOLFOX in the setting of the Checkmate 649 trial. So here you're also looking at frontline gastric and GEJ, gastroesophageal junction adenocarcinoma, 507 patients with CPS greater than 1 or another subgroup with CPS greater than 10. And you're comparing the addition of pembrolizumab added on to cisplatin 5-FU versus the chemotherapy arm. And here we don't see a difference in terms of the primary endpoint of median progression-free survival, which was fairly equivalent at 6.4 versus 6.9. And also in the median overall survival of 12.5 versus 11.1. So this data, even the overall response rate was higher at 48.3 versus 33.1, this data did not lead to a superiority with the addition of immunotherapy, pembrolizumab, to cisplatin 5-FU. So why is it that in the KEYNOTE-062, you do not see the benefit of immunotherapy in the frontline setting? And that benefit was not seen in both the CPS greater than 1 or the CPS greater than 10 cohort. And when you look at the Checkmate 649, the CPS was only greater than 5 to get a benefit. So the other thing that may be different is maybe the chemotherapy component arm is driving the lack of benefits here, in that with KEYNOTE-062, you see cisplatin. The 5-FU is obviously similar to the Checkmate 649, whereas in Checkmate 649, you're using oxaliplatin. That's sort of a hypothesis would probably need to be looked at in further detail. In metastatic anal squamous cell carcinoma, in the SAUCY PUDI 60 trial, again, you have modified DCF, docetaxel cisplatin 5-FU, plus the atezolizumab versus standard of care modified DCF in frontline anal squamous cell carcinoma. Again, we see no statistical significance in the 1-year progression-free survival rate of 43.2 versus 44.2. The overall response rate is equivalent. So, is this data negative? Again, it does involve cisplatin, but again, that's conjecture. There are ongoing trials looking at carbotaxol plus IO versus carbotaxol alone in the frontline setting. So we will get more clarity with that data going forward. Next, I will look at frontline setting with metastatic colorectal cancer, Checkmate 9X8. 195 patients. There was a less than 8% MSI high patients. Looking at modified FOLFOX6 plus BEV plus nivolumab versus chemotherapy arm in the frontline setting of metastatic colorectal cancer. Here we see that the median progression-free survival primary endpoint was not significant, 11.9 in both arms. The overall survival also was not 29.2 versus not reach. I think I had that backwards, probably. And then the overall response rate was 60.7 versus 46. The interesting thing about this trial in Checkmate 9X8 in frontline metastatic colorectal cancer is that you see there's a divergence of the curve after about 12 months. So it does suggest that the patient who got nivolumab, a subset of those patients benefited long-term. And again, with immunotherapy, you're getting this tail that you typically don't get with chemotherapy in the metastatic setting. And so they did a sort of a more exploratory analysis looking at why there's this divergence with the immunotherapy arm. And they were able to find that consensus molecular subtype 1 and consensus molecular subtype 3, which represent the immunogenic and the metabolic consensus subtype, they were able to show that there was that divergence if you select out those subtypes in comparison to CMS2 and 4. They also did it with CD8 positivity, and they were able to show that CD8 positivity also allowed for the seeing this divergence in the subtype. And so maybe that will give us information about how to go forward in terms of looking for biomarkers to try to find out which of these patients will benefit from immunotherapy, even if the data overall may appear negative based on median progression-free survival. This also raised the interesting idea of, is median progression-free survival sort of the end-all for analysis in metastatic colorectal cancer? I mean, how do we take into account of this tail? Because obviously patients do benefit if they are alive long-term, whereas you don't see that with chemotherapy. So I think that's sort of food for thoughts. And then lastly, I will focus on this exciting data that was presented recently at ASCO in rectal cancer with MSI high or DMMR status. So here, it just goes to show that if you apply immunotherapy early on in earlier stage 1 to 3, as you see on the right side of the table, in the neoadjuvant setting, there was data presented by MSKCC with dostarlimab, showing that they were able to get a 100% clinical response rate, which is very impressive. Now, these patients, typically in stage 1 to 3 neoadjuvant rectal cancer patient, would receive total neoadjuvant therapy. They would get chemotherapy followed by chemoradiation or vice versa, followed by surgery, which is fairly invasive treatment. Here, these patients in the MSKCC series got 100% clinical response, and they were able to avoid all the toxicity of chemotherapy, chemoradiation, and surgery. So that was very impressive data. There was also data in the literature from the PIC trial and the NICHE trial showing that you're getting 65% pathologic complete response and 60% pathologic response. Again, these responses are very high, and we all know that pathologic complete response is a very favorable prognosis factor. And so when you look at on the left side of the table and you look at stage 4 first line and stage 4 second line in those trials with immunotherapy, you see that the pathologic complete response was much lower. So again, it sort of brings the idea that if you give immunotherapy in the earlier line setting, you're gonna get a stronger benefit, perhaps because you're not, the tumor are no longer not able to develop immune resistance. So overall, my perspective is there are current evidence for IO efficacy in some GI cancer. I didn't speak about pancreatic cancer because it's been negative so far for immunotherapy. I think there will be a transition of IO exposure to earlier stage tumor prior to the development of increased immune resistance. And I think there's an unmet need for a predictive biomarker and also trying to identify synergistic IO combination. And at the Angeles Clinic, we're looking at a lot of these IO combination trials to sort of improve the therapeutic efficacy.
Okay, that's great. Great information on where we're going with GI cancers. And as you can see, the theme continues here of metastatic data being presented and being then moved quickly into the adjuvant neoadjuvant space for greater patient benefit and a need for newer combinations in the later line settings. And with that, we'll bring you to Dr. Wenzel to close us up here with current and future considerations in GU carcinoma. Dr. Wenzel.
All right, thank you, and good evening, everybody. Quick outline of my presentation here. I'm first going to start off going over renal cell carcinoma, discuss a new standard of care in adjuvant therapy that was recently published in the Keynote 564 study. Then move on to urothelial carcinoma and discuss the Javelin Bladder 100 trial, which represents another new standard of care now in the first line treatment of advanced and metastatic bladder cancer. And then if I have some time, I'm going to shift gears a little bit and go over some recent and ongoing trials that I think we should have on our radar, which will include the Cosmic 021 and the Stellar 011 trial. For decades now, partial and radical nephrectomy have really been the standard of care for local regional clear cell renal cell cancer. However, with its curative intent, we know that a good majority, nearly half of patients actually will recur with disease recurrence. And unfortunately, a lot of times that disease recurrence does come in the form of metastatic disease that is life-limiting. There's several known risk factors for disease recurrence, which include the size of the primary tumor, whether or not there was lymph nodes involved at the time of surgery, the pathological nuclear grading, as well as the presence of tumor necrosis. In an effort to try and prevent these recurrences, there was early adjuvant trials done during the cytokine era, looking at adjuvant interleukin as well as interferon-based therapies. However, all of these failed to demonstrate any significant improvement with regards to disease-free survival, relapse-free survival, or overall survival. With the emergence of TKIs playing a huge role in the advanced and metastatic setting, many large trials looked at their use in the adjuvant setting as well, however, with fairly mixed results. Of these adjuvant trials, there was one positive study that you see here, the S-TRAC trial. This looked at sunitinib versus placebo for 1 year after surgical resection. These patients were high risk of recurrence that they defined as a T3, T4 lesion or node positive disease. And they showed a significant benefit in their disease-free survival with a hazards ratio of 0.76. However, this benefit did come with significant toxicity. Anybody familiar with the use of TKIs? The majority of patients had grade 3, grade 4 adverse events, with nearly a quarter of the patients on the S-TRAC study discontinuing therapy because of those adverse events. And just over half of the patients actually completed the full 1 year of adjuvant therapy. So this here is the current NCC and guideline recommendations with regards to adjuvant therapy. And you can see here the recommendation is a current category 3 recommendation for the adjuvant sunitinib. And just to preface that, a category 3 recommendation is one that has major disagreement that the intervention is appropriate for most patients. So that brings us to what I want to discuss now is the Keynote 564 trial that establishes a new standard of care for adjuvant immunotherapy in patients with clear cell renal cell cancer and a high risk of recurrence following surgery. So this was published earlier last year or late last year in the New England Journal, and this was following Dr. Tony Choueiri's plenary session at ASCO last year. And this study was a phase 3 randomized trial that looked at close to 1,000 patients with all clear cell renal cell carcinoma, underwent nephrectomy less than 12 weeks prior to randomization, and received no prior systemic therapy before enrollment. They were randomized 1-to-1 to either pembrolizumab every 3 weeks for up to 1 year versus placebo, and the primary endpoint was disease-free survival. They had some predefined risk categories that they included, which were intermediate high risk, which included T2 disease with high grade, grade 4, or sarcomatoid features, or T3 disease. High-risk disease was defined as T4 or node-positive disease, and then there was the metastatic, oligometastatic patients that were disease-free after surgery. So the baseline characteristics, this is just to show you that they were fairly even between both groups, but I do want to highlight that the majority of patients enrolled into this study fell within this intermediate high-risk disease group. Now, the primary endpoint, as I mentioned, was disease-free survival, and at the interim analysis, the primary endpoint was statistically significant, benefiting this treatment group. You can see here with the hazard ratio of 0.68. When looking at the subgroup analysis, there was benefit for disease-free survival consistent across all of the subgroups analyzed in the study. With regards to adverse events, there was more grade 3 to 5 events in the patients that received the pembrolizumab adjuvant therapy, 32% occurring in the treatment arm versus 17% in the placebo arm, which led to a discontinuation rate of 20% in the pembrolizumab arm. However, there were no treatment-related deaths, and there was a completely expected toxicity profile associated with using pembrolizumab here in the adjuvant setting. Now, those adverse events, as I mentioned, were very typical to the toxicity profile, very known with immunotherapy, fatigue, diarrhea, pruritus, arthralgias, hypothyroidism, and rash being the most common. But overall, very well tolerated treatment in an otherwise healthy patient population that was able. We now have updated data that was just recently presented that does show continuation of this disease-free survival benefit, now looking at over 30 months of median overall survival in the patients receiving adjuvant therapy. And what's interesting is there is no further adverse events, no increased adverse events, and still no treatment-related deaths with this ongoing further follow-up. Looking at the different risk groups, we now have data across the defined risk groups, and it does show that there is improved benefit with higher risk disease, as you can see here moving across the page. And not well pictured here, but one of the subgroups that they analyzed was the patients with histologic sarcomatoid features, and they saw an even larger benefit with adjuvant therapy in those patients with a hazard ratio of 0.54. So in conclusion, this adjuvant pembrolizumab definitely demonstrated a significant disease-free survival benefit following nephrectomy for patients with clear cell renal cell carcinoma with intermediate to high risk of recurrence after surgery. Benefit was greater in high-risk disease as well as those with sarcomatoid features. With additional follow-up, there was no increase in any adverse events or use of steroids to treat adverse events, and there was no deaths related to pembrolizumab. So now I'm going to shift gears to urothelial carcinoma and just kind of put things into perspective. Historically, this was a disease that upfront platinum-based chemotherapy was used for 4 to 6 cycles. And it was very proven to get good high response rates, to get disease control. However, even with this disease control, it was very short-lived and ultimately disease progression was inevitable. Immunotherapy with immune checkpoint inhibitors has played a big role in the metastatic setting, but not so much great in the frontline setting and unable to really get great disease control when used first line. But patients that did respond to immunotherapies in the front line do show, some do show long durable responses if they are able to be achieved. So our original approach prior to the study that I'm going to discuss here was really start first line chemotherapy if possible, and then you wait and you watch for progression, and then that's when you move in with second line immunotherapy. However, the problem with that approach is that many patients, by the time they progressed, were either unfit to receive second-line therapy, or the disease became so advanced they were not responsive to this second-line immunotherapy. So the thought was that maybe waiting was too late to intervene in these patients. So as you can see here with the NCCN and guideline recommendations, each of these preferred regimens comes with chemotherapy upfront followed by avelumab maintenance therapy, which is presented well in the Javelin Bladder 100 trial, which was published a little over a year ago in New England Journal of Medicine and presented at the ASCO plenary session 2020, and is a practice-changing publication that has come out in GU cancers in the last couple of years. So this study looked at patients with unresectable locally advanced metastatic disease. They received 4 to 6 cycles of platinum-based chemotherapy, could either be gem-cis versus gem-carbo, and achieved at least stable disease as their best response. Now they randomized 700 patients to the avelumab maintenance arm versus with best standard of care versus best standard of care alone, with a primary endpoint of overall survival. So the primary endpoint with overall survival showed a statistically significant hazards ratio of 0.69 with median overall survival of 21 months in the avelumab maintenance group and 14 months in the best supportive care group. In the PD-L1 population, you can see an even a better improvement of the overall survival with a hazard ratio of 0.56, with a median overall survival not reached in the treatment arm and 17 months in the best supportive care arm. Looking at the subgroup analysis, all subgroups benefited from the avelumab maintenance. The one subgroup that I think was interesting is that the first-line chemotherapy regimen that was used, there was significant benefit regardless of which of the platinums was chosen, because we always think in bladder cancer that cisplatin is definitely the best of the neoadjuvant treatments to use, or the only platinum that is approved in the neoadjuvant setting. But in the advanced setting, either platinum therapy was able to show benefit when you add immunotherapy following a response or at least stable disease. So just in summary of this study, this is now a standard of care changing publication of using avelumab maintenance after chemotherapy in patients that at least had stable disease after their first line chemotherapy. And this has been shown to be regardless of their PD-L1 status, regardless of which of the platinum chemotherapies was used, and regardless of what response they achieved, as long as they achieved stable disease to the chemotherapy line. So with last couple of minutes, I just want to mention a couple studies that I think are important to have on our radar. And this is the Cosmic 021 that's been presented at multiple conferences in the last year or two. And then the Stellar 001 study that we currently have open here at the Angeles Clinic that we will be probably presenting at several of the conferences coming up in the next year or so. So just starting with the Cosmic 021 study, this is a phase 1b dose escalation study of cabozantinib, the multi-target oral TKI in combination with atezolizumab. And there's multiple cohorts of solid tumors involved, but I'm going to focus primarily here on the GU cohorts. There are 2 renal cell cohorts looking at clear cell as well as non-clear cell. The clear cell is a treatment naive group. There are multiple bladder cohorts that are looking at different time points of the disease, treatment naive, as well as post-chemotherapy, post-immunotherapy, and then even a metastatic castration and prostate cancer cohort after progression on novel hormonal therapy. So I'm going to go through this kind of quickly, but just looking at the different renal cell cohorts, there was 2 dose groups within the clear cell renal cell cohort with cabozantinib at 40 milligrams and 60 milligrams in combination with the atezolizumab. And you can see here objective response rates of over 50% for both of these groups. What's interesting to note is that each of these groups did have complete responses as well too. The 40 milligram dose group had 1 complete response and the 60 milligram group had 4 complete responses. The non-clear cell group had a slightly less objective response rate of 31% and no complete responses, but still in a difficult to treat population, I think this is still pretty promising response rates in the non-clear cell group. This is just the waterfall plots showing the disease control rates were were very good across both dosing groups of the cabozantinib with greater than 90% disease control rate. That goes for the non-clear cell cohort 10 as well too. There's multiple bladder cohorts that there's a lot of data that I could present on each of these, but I'm going to focus primarily on these cohorts here where we just recently presented this data looking at treatment naive, cisplatin eligible and ineligible patients, as well as prior immune checkpoint inhibitor therapy. And the main point that I want to highlight on this cohort is, if you look here on this on these spaghetti plots, you can see that you can achieve very durable responses with these patients that are potentially able to get disease control early on. And some of this follow-up data is going out 3 years plus now, and still showing very good disease control rates in patients that did respond initially. So these durable responses are definitely able to be seen here in the frontline setting with this new novel combination of a TKI with immunotherapy. So just in summary of the COSMIC-021 study, this is a combination study with cabozantinib and atezolizumab. It's demonstrating very encouraging results with a pretty reasonable safety profile that was not unexpected in multiple different cohorts, as I mentioned, even metastatic castration-resistant prostate cancer. And then that kind of leads me to the Stellar 001 trial, which is still upcoming to present further data from, but it's kind of the sister trial to the COSMIC-021. It's looking at a XL092, which is the next generation oral TKI to cabozantinib. The thought is that it has a shorter half-life and potentially could be less toxic, or at least able to recover from toxicities quicker given its shorter half-life. So thank you everybody for paying attention, and be happy to take any questions after.
Okay, thank you. So this is our panel discussion question and answer session. You still have the ability to put questions in here. If you go home and you have a question that you didn't get to ask, and you have a Jones to get it answered, emails for the speakers are first initial last name at theangelusclinic.org. So we'll be happy to answer those. We'll go back to some of the questions that have come forth, and the first one goes to Dr. Chu from mchen@multicare.org. So after the recent ASCO 2022 and NEGM publication, MSI high DMMR already asked us to give neoadjuvant IO. The patients come in asking for it. What should we do if clinical trial enrollment is not an option? How should we follow these patients?
I think that ultimately would be a sort of a regulatory question, and whether or not you can get the immunotherapy agent in this setting without regulatory approval. I mean, I think from a biologic perspective, it makes a lot of sense. The response rate is very high based on what's seen of 60-70% pathologic complete response. I think the issue is one of I think you have to look at it in terms of the bulkiness of the tumor. If it's a T4 tumor, there's risk that you're going to have a big problem. So perhaps chemoradiation in that setting to debulk the tumor so that you don't have a catastrophic event makes a lot of sense, and then follow that up with immunotherapy. I think that's sort of how I would think about it. But I think moving immunotherapy up front in this setting makes a lot of sense, and I think a lot of people will try to do it off-label.
Well, that's great. The next one for Dr. Memi, as you talked about advanced melanoma. I'm going to change it a lot because the question asks, as adjuvant IO setting, should we always use IPI-1, Nivo-3 for both high-risk lymph node positive and lymph node negative melanoma patients? So the question really is, in the adjuvant setting, is there data on utilizing combination at that time point?
Yeah, no, that's a great question. So there's been a randomized study with Ipi-Nivo compared to Nivo in adjuvant setting for high-risk node positive disease, but unfortunately that data was negative, or the trial was negative. It didn't show the benefit that we were looking for. On top of that, Ipi-Nivo comes with a significant toxicity, even though the regimen used there was more of a lung-based regimen. At the moment, there's no recommendation of using Ipi-Nivo combination in any kind of dosing format in adjuvant setting. However, the exciting part is that in neoadjuvant setting, there's a lot of upcoming data that was presented at ASCO 22 from Europe and the US as well. So I think we're looking for a follow-up of that to utilize ipi/nivo in upfront setting in earlier stages of melanoma rather than in adjuvant setting, because we just don't have the data that we could use to utilize it.
So not standard at this time for combination, aside from clinical trial in the adjuvant or neoadjuvant. Dr. Balmanukian, lots of questions have come forth about the question about chemo plus immuno versus combination anti-CTLA or PD-1 as a frontline choice for patients, and specifically those with PD-L1 less than 1%. Can you tease out some of that data, give us some guidance, or are both viable?
Yeah, this is a question that comes up frequently in this setting because we now have a significant number of choices for patients, which is great. We have monotherapy, immunotherapy treatment options for patients, those specifically for greater than 50% PD-L1 expression. We have the combination IO therapy with ipi/nivo, and then we have the chemotherapy and immunotherapy combination. So my strategy typically is to really look at the burden of disease, to look at the PD-L1 expression. I also look at the tumor mutation burden, even though that didn't really pan out in Checkmate 227 as a marker of response and really just as a marker. But to me, I do utilize that information. The most important factor for me is whether a patient has metastatic disease in their liver, because liver tends to be a very difficult place to treat patients with non-small cell lung cancer. In my experience, those who have liver disease, especially if they have significant burden of disease in the liver, benefit from chemotherapy and IO combination versus if they have disease predominantly in their lung, bone, and lymph nodes. So those patients can do well with immunotherapy. And then depending on really if they have PD-L1 less than 1%, we do know that the IO combination, there is data for that. It wasn't powered for overall survival in Checkmate 227, but as we saw in the presentation, there is overall survival data to support its use. It's just a matter of whether insurance will cover it. Covered for patients with PD-L1 less than 1%, it's chemotherapy and IO combination, or Checkmate 9LA, where it was regardless of PD-L1 expression. So those patients can get limited chemo and then ipi/nivo. But basically where the disease is, especially in the liver, really are factors for me as to what agents are going to use in the frontline setting.
Thank you. Let's talk to Dr. Wenzel here. You talked about immuno and VEGF types of therapy. What are your thoughts about combination immunotherapy in the future for GU cancers?
So, I mean, we've seen single agent of each VEGF inhibitors and immunotherapies on their own do very well in both bladder and renal cell cancers. And then in renal cell cancers, you've seen the combinations. There's now 4 different combinations approved in the front line. I think bladder is kind of lagging behind a little bit, although the data presented from the COSMIC study is promising. I think they're teasing out which of the different bladder cohorts are going to respond the best, and whether it's going to be biomarker driven or not, I think is still the question. But we're seeing the profile of the 2 drugs, the TKIs and the immunotherapies together, well tolerated for the most part, with decent responses in both RCC, well proven and working its way out in bladder.
Okay, I'm going to start and go around the horn because we got a couple minutes left. What do you think is the most exciting data coming in these tumor types? We'll start with Dr. Chu. Unmute, please. Okay. We'll start with Dr. Chu. Nope.
Sorry, I had my mute on. I think moving the IO treatment to the neoadjuvant setting in the early data will come, because given that the GI tumors have low to moderate level of TMB, getting the later line setting when the tumor may have developed immune resistance or mechanism of escape for immune surveillance, I think IO may not be as effective. So I think moving earlier stage setting is where the exciting data will come out.
Dr. Balmanukian, interesting target, interesting trial in lung cancer.
And the field of lung cancer is moving at the speed of light. There is definitely new drug development in terms of targeted therapies, and in terms of discussing immunotherapy. There's definitely, I would echo what Dr. Chu said, just the fact that now we can use immunotherapy in the neoadjuvant setting. There's also data coming out in the adjuvant setting. Atezo is already approved in the adjuvant setting, and then there's more data coming in that setting as well. So the fact that we can use these agents in the neoadjuvant setting and adjuvant setting is very exciting, and I think just overall lending to better patient outcomes.
Dr. Memi, new trial or target, not neoadjuvant or adjuvant?
I think new trials would be perhaps tebentafusp in a subcutaneous dosing, combination of adoptive T-cell therapy with various agents. Those are very exciting, and looking forward to approval of TIL in metastatic refractory melanoma. Additionally, population of BRAF mutant patients who are non-VRAF or non-BRAF V600E or K mutation in the R, the Gs, the Ds, and there are potential pan-RAF inhibitor development that's also available at the Angeles Clinic that is very exciting at the moment.
Dr. Wenzel, what's your future target? Doesn't have to be available at the Angeles Clinic.
I think what's most exciting right now is the multimodality therapy for bladder cancer and potential bladder sparing approaches, trying to combine immunotherapies with radiation approaches in the neoadjuvant setting, but possibly even in the non-surgical setting to cure patients of advanced disease with muscle invasion without surgery.
That's wonderful. Thank you so much. I'd like to thank the organizers, my colleagues who've done an amazing job bringing you into the immunotherapeutic sphere and back to the future, as they say. And of course, not to be forgotten, our supporters and the person who's really makes it happen here, Donna Short. Donna, I'm going to throw it over to you to give some final thoughts, but thank you immensely for the opportunity to speak on what powers us here at our institute.
Thank you so much again, and you guys did a great job. I love the topic that you brought to us about focusing on all the different malignancies that are dancing with immunotherapy currently and where they're all at in their progress. Like you said, melanoma started it all, but many others are quickly picking up speed and really enjoying some incredible success with patient care. So I want to encourage the faculty to stay on after the program is over. We have one more meeting. And then I would like to have Brandon go ahead and put up the Wheel of Fortune. So for our healthcare providers who pre-registered and stayed till the end, we're going to draw our first winner for the $150 Visa gift card. So Brandon, if you want to go ahead and click the press to pick a person. So this is our Wheel of Fortune. And Tanya Nino. So Tanya, thank you for pre-registering. Go ahead, Brandon, and pick our second person. So Tanya, be looking for an email from Brandon. He will tell you how to redeem that $150 virtual gift card. And then Yan Ji. So Yan, you'll also get that email from Brandon, so be looking for that. Thank you again for joining us this evening, and we look forward to seeing you on another educational program. Thank you.